It's such a pleasure to be back here at the Phoenician since the international congresses began under the leadership of Ted Dietrich. It's amazing that 35, 36 years have gone by since that time. And Ted Dietrich was an amazing person. He was 10, 15 years ahead of everyone else in innovation, bringing in new ideas and new concepts. And now we've finally caught up with some of the things that he has advocated and developed and innovated over these years. And so when we think about it, remarkable changes have occurred over the last 35 years in the management of patients with peripheral artery disease. We have all these new devices, these methods, these techniques, endovascular rules, and medical therapy has increased remarkably. But what has not changed over the last 35 years is the mortality rate of patients with peripheral artery disease. The mortality rate is 10% or more per year, which is absolutely remarkable. How could that be that the mortality rate remains so high? And if you have lower extremity peripheral disease, 50% of the patients are dead in 5 years. So this is the biggest unsolved problem for patients with peripheral artery disease. And what do they die of? Well, they die of coronary artery disease. They don't die of their peripheral vascular disease. They don't die of their carotid disease. They don't die of their aneurysm disease. They don't die of their peripheral vascular disease. They die of coronary artery disease. And we know that most patients with peripheral vascular disease have coronary artery disease. So what do the guidelines tell us to do? If you're not having symptoms of coronary disease, the guidelines say just go ahead and do the peripheral vascular procedure that you need to do. Don't do any testing for the coronary disease because we know preoperative coronary revascularization doesn't help. That's the CARP trial. That was done 20 years ago. Well, today the standard of care, if you have coronary disease, is not angiographic guided coronary revascularization, but FFR, fractional flow reserve, guided coronary revascularization. Well, now we can do non-invasive evaluation of fractional flow reserve using cardiac CT scans and computational flow analysis to give you a three-dimensional view of the coronary arteries that show you not only the stenoses, but also the fractional flow reserve values throughout the coronary tree. So now the new guidelines, 2021 American Heart Association and American College of Cardiology guidelines, tell us that patients with coronary artery disease, with suspected coronary artery disease, should undergo cardiac CT scan as the first diagnostic test. And if you find a coronary lesion, then you should do fractional flow reserve assessment non-invasively, FFRCT, to determine the hemodynamic significance to help guide the treatment and coronary revascularization. The guidelines also say that many patients who are chest pain patients actually don't have what we consider chest pain. They have angina equivalent symptoms such as fatigue and dyspnea. Women particularly have associated symptoms which are atypical, not your classic angina symptoms. And the patients with angina equivalent symptoms should undergo coronary CT angiography, coronary CT. And if you do a coronary CT scan and find a lesion, you should compute the FFR values. And now we consider patients with critical limb ischemia. They can't walk. They have no classic angina symptoms, but they do have fatigue and dyspnea. So under new current guidelines, they should get a cardiac CT scan. So if we now take that and apply that to patients with critical limb ischemia, patients who have a 50% 5-year mortality, and we do a coronary CT and an FFR CT analysis, we find that 2 out of 3 of those patients have hemodynamically significant coronary disease. 8% have left main disease, 40% have multivessel coronary ischemia. These are indications for coronary revascularization. And if we do coronary revascularization, we can reduce the mortality of patients with critical limb ischemia. And we now have such data to show that we can actually reduce the mortality by almost 50%. And over the past 40 years, the mortality for critical limb ischemia has not changed. So instead of a 50% 5-year mortality, we now can have a 25% 5-year mortality if we do appropriate coronary revascularization. So I think that's the new frontier for patients with critical limb ischemia, solving the problem of the high mortality rate. And now with non-invasive diagnostics and selective coronary revascularization, we can improve the survival of patients with critical limb ischemia.